Good afternoon. This is Noah DeVicente dictating a patient presentation for Fellows GI Fellows Conference. Let's begin. This case involves a 53-year-old African-American male who presented to endoscopist of the day for a screening colonoscopy. He had a history of hyperlipidemia, chronic back pain, and benign prostatic hypertrophy, but otherwise was healthy, asymptomatic, here just for a age-appropriate screening colonoscopy. He had no family history of any malignancies. On the colonoscopy, we found 3 separate polyps. One was a single, very small diminutive polyp, less than 5 millimeters, which was found in the transverse colon. This was removed by a cold biopsy forceps. Second polyp, also very small, less than 5 millimeters, was found in the cecum. This was also removed with cold biopsy forceps. And finally, another polyp was found in the colon, just adjacent to the appendiceal orifice. Very small, approximately 5 or less millimeters. It was taken off with a cold biopsy forceps. It was broad-based. There was no stalk to it. There was nothing particularly striking about it. There's also evidence of diverticulosis in the colon, in addition to hemorrhoids seen on Reg Reflection of the colonoscope. The first polyp, which was labeled as the transverse colonic polyp, was just benign colonic mucosa, no adenoma present. The second polyp seen near the appendiceal orifice was actually marked as a granular cell tumor, S100 positive in the tumor cells, and that's what this talk will focus upon because it's not that common to have this come up on colonic biopsies. The third polyp in the cecum was a tubular adenoma. So now we're going to focus on granular cell tumors. It's a rare soft tissue tumor which is believed to be derived from the Schwann cells of peripheral nerves. Commonly occurs in oral cavities, also in subcutaneous tissue, but like stated before, it is uncommon in the GI tract. Only 8% of all granular cell tumors occur in the GI tract. When it is seen there, it is more common in the esophagus, followed by the duodenum, the anus, and then less common in the stomach. Usually when patients present with these tumors, they're usually found incidentally. There's a equal distribution across the genders, usually diagnosed between ages 40 and 60. Commonly described as a small, round, submucosal nodule covered by normal-looking mucosa. How do you diagnose granular cell tumors then? Final diagnosis really depends on histology. There are histological characteristics which are seen by the pathologist which help us with this diagnosis. They're described as plump, histiocyte-like, bland-looking cells with abundant granular eosinophilic cytoplasm, also containing acidophilic PAS-positive diastase-resistant granules. The nuclei are uniform in appearance and very small. Mitotic figures are absent. Also, the main way to determine it is by markers, stains, including the neural marker S100. The S100 protein should be expressed uniformly on the stain. What is the prognosis of granular cell tumors once it's been diagnosed? In general, they're very good, thought to be benign overall. There are approximately 30 cases reported worldwide of these being malignant. So in general, a benign tumor. Several studies have sort of looked at this overall, looking at patient groups and seeing how their cases progressed. Those are listed in the work cited at the end of this presentation. In one study, they spoke about complete excision in 24 patients was done, and in 5 of them there was local recurrence of the granular cell tumor, but no evidence of malignant behavior. Another study focused on granular cell tumors in the esophagus. Specifically, they were treated with a biopsy, and no further excision was performed. No recurrent or metastatic tumors were then seen on these patients on follow-up. Another study dealt with granular cell tumors of the esophagus. 4 patients with granular cell tumors were followed. The mean time of 65 months, range 16 months to 10 years. 1 patient developed a new satellite polyp after a 5-year follow-up, but the rest, there were no further granular cell tumor recurrence. There has been malignant case reports of granular cell tumors, although extremely rare. There are some predictors which will make you think more about malignancy in these cases. Large size, greater than 2 centimeters, cell necrosis, spindling seen within the cells themselves, cytologic atypia and high mitotic activity, vesicular nuclei with large nucleoli, a high nuclear to cytoplasm ratio, and obviously invasion into adjacent tissues make you more worried about a malignant variety of granular cell tumor. Those were mainly talking about sort of local spread of the tumor. What about metastasis then? Since there are a small number of patients, reports of metastasis perhaps in 1 to 2% of patients. A metastatic granular cell tumor is thought to be chemorefractory in general. There is one study which showed some promise with gemcitabine in addition to paclitaxel, but that's one isolated study. So in general, chemotherapy is not effective if you encounter metastatic granular cell tumor. Once you have one of these, what other treatment can you perform? Well, one of them is you would get your mucosal biopsies on the initial exam, see on the pathology that it's granular cell, and then how would you go back for it? One issue is performing an EUS just to see depth of invasion of the cell itself. After you know depth of invasion, you could go back with endoscopic resection, just injecting saline into the mucosa and then performing endoscopic mucosal resection to get clear margins. There are some cases of surgical wedge resection, but these are actually more common with gastric cell tumors. So those are the treatment options. In our patient, just as follow-up, what we decided was to perform a repeat colonoscopy, re-examining and biopsying the area around the appendix, and performing repeat biopsies to see if there was any further granular cell tumor tissue there, and then in addition performing a CT abdomen pelvis to look for any local metastatic disease or any infiltration around the appendiceal orifice itself, or cecum. We'll follow up that with repeat colonoscopies.